Uh, so good evening, everyone. This session we thought we'll keep so that it'll be an orientation to prepare for MRCPCH clinical. Especially will be very useful for those who are giving their exams in Diet 3 this year, 2024. So our group is Target MRCPCH, and we are the mentors, Dr. Balaji, Dr. Prasanna, me, and Dr. Sabari. So I'll just say a few words about Dr. Balaji. He is working as professor currently in SRM Medical College, and I'm actually very happy and very proud to say that he has got a score of about 81 out of 82. I don't know where he even lost at 1 mark. He should actually got 82 out of 82. They probably thought we cannot give full marks to everyone, so they probably cut 1 mark here and there. Because you can see the background, he has a lot of gold medals lined up for best assistant in pediatrics, for best paper award in 2 state level conferences. And he has so many other awards with 15 years of teaching experiences and numerous publications. His main area of interest is pediatric endocrinology, in which he's even pursuing a PhD course.
Thank you, Ma. Thank you. And let me introduce Dr. Prasanna, sir. Sir, we all together did our exam, so I'm lucky to have a team to prepare together. So that is very important, actually. And sir has completed his DNB, MRCPCH. Right from his study period, he was a gold medalist in DNB. And now recently he finished his fellowship in allergy. So even in that he has scored a gold medal. So he's a very good PG postgraduate teacher for almost 15 years with numerous publications. And his core interest is in pediatric pulmonology. And I'm very happy to have you, sir, as part of the team. Not only as the team, we have sailed right from it was a wonderful journey. Thank you, sir. Thank you. And it's a good opportunity to mentor all the student candidates. Happy.
Thank you, sir. Thank you, sir. And let me introduce our friend, Dr. Sabrinath, who is with us today. He is one of the mentors, and he has finished his MBBS, MD, and he is a DM in clinical immunology and rheumatology. He has completed his MRCPCH, and he is also a rheumatology fellow, board certified fellow in pediatric rheumatology, who has a keen interest in allergy, immunology, autoimmune disease, and he has teaching experience in a medical college in undergraduate, postgraduate, and even rheumatology DM students. He has been a faculty and speaker in various national conferences. Welcome, Dr. Sabri. Happy to be here. Happy to be associated with you.
Thank you, sir. Thank you, sir.
Thank you.
So let me introduce Madam Dr. Harshna, Madam. I think the group members will be aware of Madam. Like Madam is very active in the group. Madam is she's a assistant professor in a state medical college hospital. She's a speaker and faculty in various national and state conferences, and she has a teaching experience for undergraduate and postgraduate pediatrics department. And she has a good MRCPCH clinical score. And Madam is very active in our group, and she's the leading faculty of the group.
Okay. So delay, we will move on to overview of the exams, because orientation towards exam is what is needed for successfully clearing the exam, because we are already we have our own graduation, our own patient management experiences. So we are there. We are already a good pediatrician. But the problem is, unless we train for this exam, it's going to be a difficult task to clear the exam, because they have their own set criteria for how they evaluate us. So to start with, the main aim of the exam is whether the candidate is able to progress into an ST4 level training. So whether he can move on to the ST4 level training. So basically, whether he's an ST3 level, we're not looking you as a, that is the most important, and that this examination is not for a consultant, it is at the level of ST3 level. So here they are not worried that you don't bring up the diagnosis. As long as you give a good differential diagnosis, the examiners will be happy. Similarly, whether you are a safe doctor, whether you are able to take the help of your consultant at the right time, whether you are referring the case at the right time for the ENT, the multidisciplinary team. So whether you are a safe doctor, whether you are not missing out the red flag signs and referring back them home. So those aspects they are looking, rather than whether you are coming to the diagnosis or not. So that's a very important thing you should understand in the aim of the examination. Why is it different from other exams? So most important, I feel, is time. We all have been managing cases. Everyone knows managing all the patients, but the problem is time here. So you get 6 minutes, for example, in a clinical station, 6 minutes to examine. And even in that 1 minute will be over when you are given a task, you greet the examiner gives the task, no? So 1 minute will be over in that. So you have only 5 minutes to examine and come to a conclusion as to what the differential diagnosis. Similarly, you have only 3 minutes where you have to summarize the findings, you have to give a differential diagnosis, you have to give all the investigations, what is the management plan. So everything in that 3 minutes. So I think time is a very important factor. If you are able to manage that, you have a higher chance of clearing the exam. Second part is, we have all been examined, but make you uncomfortable, and that is an important thing which you have to get adjusted to it. So you need to get trained by looking at peers. So some peers or some seniors are watching you examine. So that is very important. Similarly, third is talking. So in this examination, clinical, so far you have done all the theory part, all the MCQ part, where you need not do the talking. So in this exam alone, in this part alone, you have to keep talking. So you are not expected to know 10 to 20 pages of a condition, but whether you are able to speak correctly, relevantly for the 3 minutes available, whether you are able to talk fluently and logically the 3 minutes available. So that is what is more important. So you have to train yourself to talk rather than reading 20 pages, 50 pages about a diagnosis. This is more important, I feel. So total number of one second. So total number of stations, we have 10 stations, out of which we have one development station, which is a long station. You have 22 minutes. History station, which is also a long station, which is equivalent to 2 stations combined together. So 22 minutes. Similarly, you have 4 clinical stations, 9 minutes each, 2 communication stations, 9 minutes each, video station, 9 minutes each. So most of the stations are 9 minutes each. Each time you will have a 3 minutes before a knock will be there. Development and history alone are like 2 combined stations, so it will be almost 22 minutes. And with regards to marks awarded, Development station is the highest marks you will be getting. So you have to be more keen with the development station. 12 marks is there. Next is history station, 10 marks. And all the clinical and communication gets 8 marks each. Video station is the least, 6 marks each. So you have a total of 82 marks in this MRCPCH clinical. And at present, currently, the marks which you need to get is 62 marks for making a pass. So what is that meaning actually? 62 out of 82. Most important is, suppose I am doing a station totally failure and 0. Sometimes the examiner gives that when you are not up to the mark, you might get 0 marks. So assume that you get 0 marks. You assume that you get only 4 marks out of 8 in another station, and you get one mark less in other stations, 2 marks less. Still, you have a buffer to pass. So that is the most important point we should understand, that if we fail to perform in a station, this doesn't mean that we are going to fail. So don't take baggage, don't take the feeling that I have not performed well to the another station, because that's going to affect your performance, and that is not what is required. So your taking baggage to the another station is going to affect your performance and overall marks.
No, sorry. I think no.
Alzheimer's like pronunciation correcting me.
Please.
Alzheimer's, no?
Alzheimer's.
Dr. Fatima, kindly mute yourself, no?
Fatima, can you mute your mic, please? Thank you. Similarly, you have domains. So each station you have certain domains there. So you have to understand the domains which is used for assessing your marks. For example, in history station, not only information gathering, there will be marks for rapport and how you communicate. Similarly, for verbal and listening skills. So you get marks for also the communication skills in the history station. So make sure that you greet the patient father or mother. You greet them, you put a rapport with them, you listen to them sensitively, you ask the question. So although important, not only just the history taking. Okay, and this is the circuit. So it's like a train. Once the train starts, it stops only after 2.5 hours. So there's no stopping of the train. So you start with clinical. Someone might start with clinical station. Some might start with the development station. Some might in the history station. So as per the there will be 9 minutes for station, but the development and history alone will get the 22 minutes. The crucial, you get 4 minutes for preparation. So you have an opportunity to prepare yourself the scenario. Most of the stations, except the clinical station, there will be a scenario outside. So you can start preparing how to prepare your communication, how to prepare your history outside the station. So you get that opportunity. You are given paper for that, so you can try to prepare that. Clinical station alone, there will be no STEM. Only once you enter inside only, you will know what is the station available. So all the stations, most often you will have a 3 minutes at the end before a knock will be there, so that you have to start summarizing or finalizing your examination. All the clinical stations will be having real patients. Role players will be there for history, development, and communication. Video station alone, video will be there. The good thing about MRCPCH is the way they organize. They do it in a perfectly organized system. They give the paper, they give all the refreshments, they guide you how to move around. Except maybe you can take your own stethoscope. Even stethoscope is available. Better to take your stethoscope. So this is the mark sheet, how they give marks. Very important to understand how they give marks. So for each domain, so they assess almost 41 domains across the 10 stations. So each station will have 4 or 5 or 6 domains to be assessed. Finally, assess whether you meet standard, whether you line or below the standard. Meets the standard will get you 2 marks. So for 41 domains, when you get 2 marks each, so you will be getting 82 marks. Suppose it's a development. So the information gathering, not only information gathering, how you communicate, what is your communication style. So that also will give you marks. Okay. So this is the anchor statements, how the examiner will assess you based on these questions. For example, in information gathering, whether you are asking the relevant question, whether you are sensitively asking those questions. So suppose you are supposed to ask about the personal history, whether you are asking it sensitively or not. You cannot straight away ask, do you do drugs? No, so that becomes insensitive. So then that will drag your marks down. So instead of asking for 13 minutes a good history, suppose you are not sensitive, you might go to the borderline. So after 13 minutes of asking history, still you might get only 1 mark for not being sensitive enough. So that's important to understand. What are the statements they look? Try to look into the meets the standard anchor while practicing each time. Also, there are marks they cut drastically for the unprofessional conduct. So most often we try to be, we spend so much money, so we try to in the exams, but sometimes we forget these little things which brings us very much down. One important thing is the hand hygiene. We sometimes we forget the hand hygiene. We are not sensitive to the patient needs. Suppose the patient, one of Dr. Prasanna sir used to say, one patient actually want to go to the bathroom. So then you have to stop your examination. You have to talk to the examiner, sir, the child needs to use the washroom. So that sensitivity to patient needs might fetch you more marks. The examiner will award marks, even though you have not done the examination. So that's very important to understand. Being sensitive to the patient needs, being sensitive to pain and discomfort. Suppose the child says the child has pain while walking, try to avoid such discomforting or it will bring your marks down in drastically. Before final moving to the other slide section topic wise, what examiner looks, there is a bias in the way examiner assesses you. So the most important bias is whether you look confident or not. Confidence is the solution here to the marks. The examiner looks whether you are confident in your skills, whether on a regular basis. So for bringing that confidence, what is needed is preparation. So we have to prepare ourselves repeatedly so that we can do it confidently in the need good study partners, not only for studying, they should also support you. Also, the preparation phase. So we need partners to support us emotionally also. Not only study partners, we need guidance from experienced mentors. So whether we are doing it right or wrong, we will be practicing regularly with our groups, but we need to have some senior mentors. You can examine before you, someone who has finished before your seniors. So whether I am doing it right or not. Preparation, everyone can have their own preparation time. We used to, when we were preparing, at least 3 to 5 hours per day is needed. And in that minimum 2 hours of practice time is very important. So no point in reading books alone. So you need a 2 hours of minimum practice time. And for clinicals, talking the way gives you a proper order that's accepted, but unless you see cases, it's going to be difficult. It can pull you down the marks if we don't keep seeing cases. So seeing cases is very okay. And regarding books, the standard books everyone talk about is MRCPCH. It's like Bible for MRCPCH, so don't miss out. So they they don't expect too much from it. And competition,
वो स्टार्ट करते फ्री पे मार्क बेटे रिबेका कहते हैं
Rebecca, can you mute a minute? Then you have your PIP guidelines, okay, pediatric guidelines, patient leaflets, then a lot of clinical videos and YouTube videos are there. You have notes available from WhatsApp groups. So all this you can utilize, but we need not be extensive in reading. What needed is practice. Reading a lot of information is not going to help. Whether you are able to talk sensibility, the basic stuff for 3 minutes, whether you are able to talk the clinical features, differential diagnosis, investigation, all in a short span of 3 minutes, logically, that's what is going to help you. So with this, I will hand over to Dr. Prasanna sir regarding communication station. We will take the doubts at the end. Any other inputs, sir, you can add also, sir. Dr. Sabri also, you can add about the format. Dr. Harsha, you can also add.
Sir, as you said, it is the sensitivity towards the patient is very important. In clinicals, we have only in clinicals we are in contact with the patients. So rest all is going to be a role player or with the examiner. So especially if we are going to be with the patient and we are going to be sensitive enough, then it will add more marks. For example, when I did the exam, the boy was having chills. He said, "I'm feeling cold." But I have to finish my CNS examination fast. But he kept on repeating, "Sir, I'm feeling cold. I'm feeling cold." Even the examiner was not interested in addressing his concern. So what I did is I stopped and then I said, "Please switch off the AC, sir. We'll just manage with this." And then he agreed and we switched off the AC. It took some time, but still I think I was not perfect in my answers in that station. But still, I got good marks in the station. I think that that sensitivity part helped me in getting through that station. So I think small things like that. The child may say, "I'm having pain," and if you continue with your examination, then it is very difficult. So they may even keep some fractures or some swellings in the MSK station. And if the child says, "I'm having pain," you have to look at the examiner and see what his idea is. If he says, "Stop and we'll just discuss," we'll just discuss. But if we continue to examine that child, then it can be a little catastrophic. So that point is very important, as you said, sir. So I'm here to talk about the communication station. 1 minute. So communication station. Sir, can you move to the next slide? Okay. So the aim of the communication station is actually to test the candidate's ability to communicate appropriately, be factually correct, the information given in an effective manner within the time that is allotted to us. So here we'll be having certain hidden agendas, and we should be practicing so much to cruise through those hidden agendas. So for in communication station, the rule is we have to talk 40% and allow the role player to talk 60%. So if you allow the role player to talk more, then they themselves will give you all the hidden agendas. So if we are going to communicate and if you are going to have lengthy sentences, then we'll not have time for the role player to talk. So there we may miss the bus. So and we should always see the opening statement in the communication and the given task. So the task is they may have simple task. The task is the child is already a known case of UTI, and you have to discuss the DMSA reports only. So if at all you are going to talk about UTI, VUR, all these things about the antibiotics, so don't worry, all these things, then we may miss the bus. So here we have to talk about only DMSA. So we have to jump directly to the task. We will not waste time in discussing other things. Can you move to the next slide, sir? Okay, so these are some of the scenarios. The scenarios are maybe in these topics, you have to give some information. You have to probably tell the parents about some diagnosis. Then you have to give some breaking bad news. So they may already know the diagnosis. We have to tell its implication, or they may be waiting for some reports. They may know that this may be there or may not be there. So we have to tell the breaking bad news. Then it can be obtaining consent, or it can be some critical incident. Means the child would have been given a wrong drug, or a wrong dosage, or a wrong time, or a wrong duration. So then it could be a critical incident, or there could be ethics. So ethics will have set protocols for the ethics, and we have to discuss on all these 4 topics. And then it can be an educational task, like you should address a junior colleague, and you should ask them to know. So for all these communication scenarios, there are certain set templates. So if at all you practice and get accustomed to certain set templates. So for example, if there is a template where how you differentiate between information giving and breaking bad news. So for example, if the patient knows already that the diagnosis, then it is mostly information giving. If the patient doesn't know the diagnosis, and if you're going to give the diagnosis then in the examination, then it is probably breaking bad news. And you should observe the role player, what he is doing. If he is going to cry, or if he is going to be little anguished, then you should think that it is going to be breaking bad news. And in breaking bad news, if you are going to put a lot of information, draw and show, and then they will get annoyed. So you have to identify whether it is information giving or breaking bad news from a simple tip. So these are some of the tips that in this course that we can even suggest you. We can tell you what will be that set template. Next slide, sir. So these are some of the normal scenarios you can get. One part will be such normal scenarios. The other part is going to be some difficult scenarios where even a breaking bad it could be a difficult scenario. Talking to a teenager can be a difficult scenario. Talking to a difficult colleague can be a difficult scenario. So you can have 2 types of communication session. And we do follow the recalls. The RCPCH recalls are coming then and there, and we are following the recalls. But be very ready to get a bouncer. So there is 2 bouncers allowed in an over. So you can still get at least 2 bouncers in your 10 ball match. So this is going to be a 10 ball match, and you should be ready to get a 2 bouncers. So they may throw in. Suddenly they have started giving newborn history. So like that they may throw in some bouncers. So we should be ready. You should practice those tough scenarios also. So here this communication station is not about the bombarding of information. It is about how we should give the information, collect the data, and discuss that. That should be the attitude. As I said, it should be 60% from the role player and 40% should be from us. And since the time is very precise, and remember, the examiner is not going to open his mouth in the station. He'll just sit in one corner and he'll keep observing you. Even his eyes will not blink. He'll be watching whatever word we are going to say. Yeah, it is as if we are going to talk to a real parent. So we should avoid the superfluous, and we should avoid irrelevant questions, and we should be very, very precise to the point. So if we know something, we can tell, or you can even tell that at this point of time, I don't have the information needed for this. I will refer, or I will ask my consultant to talk to you. We will have another meeting. So even if you don't know anything, one of my friend had a ethical station, and he didn't know anything about that ethical station. He said to the role player that I don't know. I will go and refer. Do you have any queries? So the role player put in some questions and they finished the station. But to his, he was so happy that he got at least 6 to 7 marks in that station without knowing anything about the station. So he was very honest. So I think you should not give false information, or we should not give any superfluous information. That is what is needed. Honesty is very much needed in the communication station. Next slide, sir. So in the communication station, you'll use the 4 minutes that is given outside thoroughly, and you should read the stem, and you should mark what all. Most important thing is when you read the stem, you should be thorough with the parent's name and the kid's name. The examiner or the role player will get annoyed if you are going to mix either of these. So these are the father is Peter, father is Peter, father is Peter. So you should wait outside and keep practicing that. So these are all things we'll practice in our upcoming classes. So the role player actually may take the role of a parent. He may be a teenager, he may be a student, he may be a trainee, or sometimes the role player can even talk over the phone. So he'll sit and he'll talk over the phone, so that it may little bit confuse you, but you should be ready for all this. Next slide, sir. So this is one of the sample communication scenario. So you'll be given a big stem like this. But remember, you don't read all this. You know all already that you will be given 9 minutes. You will not be asking any history. You will know that you are not required to examine the patient. So you will be given a bill at 3 minutes. So you'll not waste your time on all this. You'll directly go here. You are the registrar. You'll be talking to David Milligan, mother of David Milligan. So David's asthma, about David's asthma, round this, and then you read the stem, and then prepare your questions, or prepare your station outside. So you'll just have to go through all these important points. Here, the most important thing is David is the son and Mrs. Milligan is the mother. So you have to address them by word, by their name. So that is most important. And if at all you forgot, then you can say your kid, or Mrs. Madam, or something like that. But you don't change that. So that is very important in this scenario. The examiner will be observing all this. Next slide. So this is how it's going to be. Next slide, sir. Oh, so we have come to the next station, the history session. I think Dr. Sabri, you will be taking the history over. If you have any doubts, or if you have any comments, please put it in the chat box before this gets over. We'll just clarify your doubts here itself in the introduction classes. And then we'll have the subsequent classes. We'll share about the details of the classes in the group, and we'll take it from there. Sabri, can you take over?
Yeah, yes, sir. Thank you, sir. So I'll give my viewpoints on the history station. So history session is where you have a long session, pretty long session, and you have 9 minutes with the examiner. So my thought is like, if at all you are reading something for the theory part, it is more often going to be useful in this station, okay, rather than any other station where our knowledge is being tested. The theoretical knowledge will be useful for this station because you have 9 minutes with the examiner here. So you'll be waiting 3 minutes outside the station, okay? So you'll be given information sheet, and then you'll have 13 minutes with the role player. So after 9 minutes, you'll have a warning for the rest of the 4 minutes, and then 9 minutes with the examiner. So, so this is a pretty long session. Thing is, you have to be ready for the scenario. You have to finish your history within the time, at least cover all the subtopics in your history. Then you will also be with the examiner for the plan for the next 9 minutes. Next slide, sir. So what is really expected and not expected in this station is, so we need to take a focused history. So it is pretty much understandable that we'll not be able to take a full history in whatever time 30 minutes we have. We'll not be able to take a full history of present history, past, social, and vaccination history. Everything cannot be done within the 30 minutes, but we need to take a focused history depending upon the case. And there is not a requirement of an exact diagnosis is often not required. If at all we are able to give a differential diagnosis of 3 good differential diagnosis, that is fair enough for the station. And more than the diagnosis, the problem areas should be identified. So instead of saying the particular pinpoint diagnosis, we can tell these are the problem areas. Say, for example, this patient had some problem in the past and some problem in the school and some problem with the family. So those will fetch you more marks rather than pointing towards exact diagnosis. And at the end of our 30 minutes, we need to summarize. Okay. So here, one thing is, we not tell the whole history again. So we need to just give the positive points and briefly tell what is the hard-hitting negative point. So only those things can be told and not summarize the whole thing. And we should highlight all the problem areas, whatever we got from the history, 30 minutes with the patient. And regarding the management, once again, we need to pitch in the team which is required rather than the exact drugs or exact investigations, exact dosages. What is expected here is whether we are involving a consultant, whether we are getting help from our other colleagues. So those are pretty much expected in this station rather than going for the specific investigation or specific sign or specific drugs and dosages. Those are not required for the station. Next slide, sir. So I think most of us will be aware of the topics which is asked in the history station. There are some around 30 to 40 topics. Most of them are chronic topics, chronic illness. So the approach will be slightly different depending upon the scenario. Say, for example, if this is the case of an joint pain, the initial information given is the child is joint pain. So in that case, we'll be asking history system screening to say what is the diagnosis. So we'll be spending more time on the initial part of the history. After that, we will go to the past history and other things, family history, so on and so forth. But there can be another scenario where the diagnosis is already given. Say, for example, this is a case of an asthma. So a child with a poorly controlled, known case of an asthmatic and he is poorly controlled. So talk to the mother. So that is a scenario. Then in that case, it is more often, we know the diagnosis already. So we need to underline why this child is having exacerbation right now. So whether he's having some problem, he's having any comorbid illness like an GRD or allergic rhinitis or any other skin problems. So he is having any difficulty in having access to the care and any stress in the family, any like any passive smoking in the family, any exposure to pet. Those are the things expected in this scenario. So the timing will be different. So how we are going to the 30 minutes, whether it is like 9 minutes for the present illness and 4 minutes for the other part, or whether we are going to give more time to the other part, depending upon the case. So we will discuss all those things in the forthcoming sessions. Next slide, sir. So this is the blueprint for the marks. So if you look at the marks, I just want to point out this one. Whatever history we are gathering in the 13 minutes, it just fetches you 2 marks. Okay. So, say for example, the mother is telling, I just lost my job, doctor. Then immediately, if he asks, do you have any pets at home, or what is your husband doing? So that becomes an inappropriate way of communication. So our communication skills and our verbal and listening communication skills, those carries 2 marks. So the mother says that I lost my job, then we need to say, oh, I'm sorry for that. So like that. So those things are more required because in the essence of examination, we will just try to tick our boxes. We will try to ask all those history, but we will miss out the communication skills. Okay. So that may happen because of the stress of the examination and the limited time what we have. So we need to be very clear in our approach, like, so what marks the history is going to give you and what marks the communication skills is going to give. So if you see here, it is 2 marks for information gathering and 2 marks for clinical reasoning. What are differences we are giving? And 2 marks for the management planning and 2 marks for the communication skills and 2 marks for the verbal and listening part. So overall, if you see here, we need to have some amount of background knowledge to come to the diagnosis. So that requires some amount of reading. But more often it is a skill of practice. Like we need to establish the rapport. We need to be sensitive to the patient needs, and we need to empathize here also. And these are the things which will fetch you full marks in the station. Next one, sir. So the next one is the video station. So here, if you have the framework is like we have 3 minutes outside, so where we'll be given an information sheet, and then as you go inside the station, there's a 3 minutes, and the examiner will be given the option of listening to the video with or without an audio. So we usually it will be like around 1 to 2 minutes of a video. So whether we are going to utilize those 3 minutes fully for the video, or once we have an appropriate differentials, whether are we going to think what we are going to tell, that will be making a difference. So we will discuss all those things in the coming sessions. So after seeing that video, there will be 6 minutes. Okay. So here there will be 3 minutes, and there's a 3 minutes warning after that. And so we will be talking about what points we will ask in the history, and what points we will see in the examination, and what investigations we will do. After that, the examiner will take to a provisional diagnosis. Say, for example, we are listening, we are seeing a video of respiratory distress, then the examiner might say, okay, considering this as bronchiolitis, how you will manage. So from that point, it will be very specific management. Overall, if you see here, the video session is like, basically it is meant to assess your skills in an emergency setting. Next slide, sir. Next slide, sir. So whenever we are going to observe a video, we are going to describe it, what has happened before the event, during the event, and after the event. So our observation skills are very important. Just like in a clinical examination, we need to comment about the surroundings, if the child is looking dysmorphic, any distress, so on and so forth. So all those observation skills are going to matter here. And what are the signs specifically this video is meant for? Because every video will have particular signs to be watched out. So we need to pick up those signs. And what are the differentials? Rather than going for a particular diagnosis, we need to give a differentials. I would suggest giving 2 or 3 differentials. The maximum 3 differentials is good enough. At least 1 differentials for a rare and maybe a hard-hitting event like a malignancy. After that, 2 common differentials in the initial part. Okay. Then after that, we need to formulate a plan and the initial management depending upon what the examiner is giving you as a diagnosis. Now, what is not required here is we do not tell about the extensive investigations. We can very well tell the team involvement rather than going for the full investigations. We will also tell about what help we will take, what are specialties we will involve. So those things are required rather than telling the full treatment plan. And we need to know the guidelines, because everything is, the question will be asked on the guidelines. Okay, so whatever there in the guidelines, it is be essential to know all those things. We need not know about the newer treatment options or the recent advances are not required essentially. And we did not assume the specialist role also. Say, for example, that's a case of an, for example, an a seizure or something like that, or a cyanotic as well, something like that. We need not tell what the cardiologist is going to do. We will just tell that we are going to pitch in the cardiologist for help. Okay. So, other thing is like, we need not tell, like, once again, the final aspect of the doses, those are not required. We just need to tell the approaches. So if you read the guidelines, then just remember the flow chart. So whatever thing is there in the flow chart that is like required, rather than the final aspect like a dose and all those things are not required. Next one, sir. Next slide, sir. So I think this slide is something not coming properly. It's okay. So what are the common things we can expect in a video station? So probably it's an emergency which we cannot be kept in a clinical station, or it is an infective scenario like a measles or something, xanthomatous illness, which cannot be once again brought into the clinical stations. Or it can be a scenario where it is a rare event, so it cannot be brought, like, say, for example, Kawasaki disease or something like that. Other thing is, say, for example, when the patient has an discomfort. Say, for example, a patient is having an pleural effusion and tabbed, and he is having an intercostal drainage. Those things are very difficult to bring into the clinical scenario. So these are the gross areas which we can expect in a video station. So one thing is an emergency. Commonly what we see is an emergencies, because those cannot be brought in the clinical stations or anywhere in other stations of MRCPCH. So that is the crux of the video station. Next one, sir. Next slide, sir. So if you see the markings here, so we have 2 marks for the signs. Okay, so whatever the important sign they're picking up from the video, so that carries 2 marks. I would say we will divide this into 3 parts, like what is happening according to the event, like before and after and during the event. Okay, as well as the surroundings. Okay, so even if we miss the particular sign, we will be able to describe the overall picture of what is happening there. And 2 marks for the clinical reasoning. So what are the differentials we are going to bring in, and how we are going to put the differentials like 1, 2, 3 based upon our reasoning. And finally, the management planning. Here, the examiner tells you, considering this as so and so. So how are you going to proceed for the management? So this is the examiner will give a clue, like considering a provisional diagnosis, what will you manage? So this carries a 2 marks. So if you see here, it's like it's overall test of your knowledge about the guidelines and your approach to the video station. So that's all from my end. And the one station which often keeps getting repeated again and again is video station, right? Yes. Exactly, that Bell's palsy that kept on coming again and again. So if recalls, most important not to miss out is videos, I feel. Yes, yes. Dr. Harsha?
Yeah, sir. Hope I'm audible to everyone. So one tip that I thought I'll share for video station is usually the video is played in a laptop, and they'll keep a headset attached to the laptop for the audio so that it is not heard outside, because in some centers there can be multiple cubicles in the same room. So to avoid audio noise, they'll keep it. So sometimes you'll forget in the stress and the anxiety. So you should make sure that you put the headset on so that you can hear the audio. Sometimes audio itself can be the only station, the only clue to the video station. You can be just a strider, and then you'll have to discuss clue. So you'll have to keep that tip in mind. And I'll continue to go on to the clinical station. So in clinical station, the main aim is that they assess the competency in clinical examination technique, as in whether you're able to follow the scheme, the format in which the examination has to be done. Of course, we all would have learned examination techniques, we all are well versed, but then there is always a fine tuning that is needed, because MRCPCH format is slightly different from what we have always practiced. It might be quite easy for those who are based in UK and probably in Europe, because that could be their regular way they do the examination technique. For others, there is of course MRCPCH, like what Dr. Balaji had already shared in the previous slide. MRCPCH shows scheme, especially techniques to do examination in an infant. When you're asked to do an eye examination in an infant, sometimes infants can be kept in clinical stations, versus how will you do an eye examination in a child. So those schemes, those format is very important. That's where they assess your competency. And based on your examination technique, whatever you did, are you able to find the clinical signs? For example, you're asked to do motoric system examination, whether you're able to say that the child has increased tone and exaggerated reflexes. That is also assessed. And based on this, you found out that there is increased tone and there is exaggerated reflexes. Are you able to tell whether this comes under the umbrella upper motor neuron lesion? That is what they see as an approach to your clinical findings. This says that you have knowledge, and this says that you've actually seen patients of this type before. And then once you can put up an umbrella, whether you're able to give some differentials, and based on that, whether you're able to do management planning. Before COVID, before the partial face-to-face came into place, management planning was not a part of the clinical station. But now they have included that as part of clinical station. Initially, it was only RAPO. But once they had no patients, and then they had to put in something else other than RAPO, management planning came into place, and it has stayed. Like for 3 minutes, they discussed everything about the case. So next slide, please. So the number of clinical stations in the exam is 4, as already discussed, and there is a separate examiner for each station. There is a waiting time of 4 minutes outside, but then you don't do anything. You won't know anything about the stations inside during the 4 minutes. It's like relaxing after going through a whirlwind of stations and all those scenarios. And then once you enter, they'll give you a scenario. The command is given only after entering the station. Examiner will be there with the patient. And this is all you already know. 6 minutes of examination, followed by there's a warning bell. Once the warning bell is done, you'll enter into discussion. Excellent, please. So any one of the following systems can be the base of the clinical station, but it's usually not restricted to one. For example, you have a dermatology station. Like it is usually how I've put the table here is that the left one is all major systems. The right one is usually comes in the other station. The right side, whatever I've mentioned on the right side, ophthalmology, dermatology, hematology, they all usually come in the other station. The 1, 2, and 3 are usually one of the systems, either cardiovascular or neurology or respiratory or abdominal. And fourth one will be others. So if it is a dermatology station, you do an examination of the skin, you find out that there is a Caffioli spot, or there's an ash leaf macule and Sjagren patch. So it doesn't stop with that. I mean, you cannot do examination for 6 minutes either. So the examiner will expect you to proceed on to neurological examination, because you might think of tuberous sclerosis, you might suspect tuberous sclerosis. So if you are able to pick that up, that is why now there is no system-wise clinical stations. They just usually before they used to put cardiovascular station, neurological station, dermatological station on the outside. Now they have stopped that, because even though it's a dermatological station, you might have to proceed to neurological examination because you picked up neurocutaneous markers. So these are all just a background of what the child can have as diseases, but then it is not restricted to just that examination. So the domains on which clinical station is assessed, like the aims will be the ones that will mark based on which marks will be given. So physical examination technique, based on which how you can identify the clinical signs. And once you identify the clinical signs, whether you're able to give a clinical reasoning, that is, like I said, when the tone is increased and the reflexes are exaggerated, whether you are able to tell that it is an upper motor neuron lesion, that is important. So each of these carry marks. And whether based on your umbrella term, whether you're able to give a differential diagnosis and management planning. And each of these will have 2 marks maximum. So a total of 8 marks is given for clinical stations. Next. So these are examples of how the command can be inside the clinical station, because every clinical station is a surprise for you. And usually clinical station will be a bit tough compared to others, because each center will have a basket of cases. So they might keep any case. For example, it can even be a mixed CP or a dystonic CP. Though we'll usually expect a quadriplegic or a spastic diplegic CP, it can be anything. So the commands can usually be a surprise. And based on the commands, you are expected to stick to the format of or scheme of examination. So some of the examples are, this is Anita. She's 14 years old and has difficulty walking. Can you please undertake a peripheral neurological examination? So then you'll have to do both upper limb and lower limb examination within 6 minutes. So you can understand, most of us will be used to doing minutes and minutes, probably 30 minutes, 40 minutes of case presentations. But here you'll have to fit in the entire motor system examination in just 6 minutes. So you can imagine how accurate and how much of a good flow you should have to complete the scheme of examination in 6 minutes. So that's why we expect you to see more cases and practice as much as possible. Or it can either be examined the abdomen of this 11-year-old child, or it can be the example 3 says this is Richard, he's 7 years old and has been referred by his GP after finding a murmur during an examination for a chest infection. So please examine the CVA system. Sometimes it can just be a superficial command like examine his chest. That means the examiner wants you to identify whether it is RS or CVS and then go into it, into that system examination. So usually it can be specific, like do a lower limb motor system examination, or it can even be very vague, like examine his chest, and it can even be confusing. Next slide. So I'm done with clinical station. If anyone has any doubts, please type in the chat box. One of the mentors will definitely answer. So moving on to development station. Development station is like the biggest station that you have because it is for 22 minutes and it does the highest marks of 12 marks. It is usually scenario-based stations post-COVID. Post-COVID, they've stopped keeping patients in development station, though they could change clinical station into face-to-face, like with patients. They haven't been able to do that with development because development more with role player has become easier and better to assess compared to when they had kids, because now more than being a development station, it has become a neurodevelopmental station, as in you won't just assess the child for the developmental milestones. You will have to find the etiology which could have caused the child's developmental delay or developmental regression or whatever issues the child has with the development, and whether you're able to give a management plan based on your the issues that you have found and the problem list that you've made based on your the way you assess the child. So these are scenario-based stations, no patients. Usually 2 types of cues are given to you during for any developmental scenario that is given. One is universal cues and another is dependent cues. Universal cues are signs that any candidate can discover just being in the room. As in you enter, usually during assessment, you'll say that I'm entering the room. You will have to verbalize as though you're doing the examination. So I'm entering the room, I'm observing what the child is doing, and immediately you can pick up that the child is in distress, or immediately you can see that the child has some dysmorphic features like Down syndrome. Those all will be universal cues. But then dependent cues are when you will have to physically examine the child. Only then you will be able to find out. These will mainly be milestone assessment, but then not just restricted to it. It can be inclusive of other things also. I have put an example. I would like to see how many blocks of height tower that the child can make. I mean, how many blocks of tower the child can make. For example, if it's a 3-year-old child, will take about 10 to 12 cubes. We'll make about 10 to 12 cubes for a tower. So these are all different cues, and you can do you can get the answer only if you do the assessment. There are other cues which are usually not, it is not common, but then it can, you cannot say that they won't keep it. There can even be a small video recording that is provided at the start of the station outside the station when the scenario is given. This was followed when during COVID, when they kept no patients face-to-face examinations. Or when there was no face-to-face examination, sometimes it even happened online. So at that time, they kept a small video. Now they don't do this. It is very rare. They don't even keep a picture outside. Before and all, they used to keep a picture of the dysmorphic child. But now even that is not being done. You're just given a STEM outside, and then based on your history and exam assessment, you will have to proceed with it. Makes sense. So the 4 domains, any of the 4 domains can be assessed: gross motor, fine motor, speech and language, or social. So for gross motor, it will mainly be function, whether the child is able to walk, run, and in fine motor, it's mainly vision and how the child is able to manipulate with things, the small movements. Speech and language focuses on hearing and speech. Like, so vision will be assessed along with fine motor, and hearing will be assessed along with speech and language. And in social, there will be behavior and how the child is able to communicate, whether you're able to assess all that behavioral challenges. Next slide. Okay, so this is the toy list. I have put both from MRCPCH website only. For gross motor, which of these toys do you want to choose? And for fine motor, which ones do you want to choose? And when you're assessing speech, which ones you want to choose? You will have to choose at the start of the station. So these are the list. The right side shows a list of toys that will be kept in all your developmental stations universally. Anywhere, any part of the world, wherever you take the exam, these will have to be there on the table. The RCPCH recommends that every center has to make ready of these things, and whether you're able to choose, that will also be taken into consideration, because that will give a clue that you know how to assess each of the milestone. So this is important. So one tip is that you can buy some of these, because these are all just small things that usually even your kids might or your cousins might play at home. A cup, a spoon, a doll, a ball, a comb. So you can probably get all these at home and practice these at home, so that you get the flow when you actually go to the exam. Usually development station, I think, is the scariest. Even for me, when I was preparing for my exam, development station was the scariest for me. But the more we practiced among ourselves, the more confident we became. So you're keeping these toys ready. Usually Dr. Balaji will have a big box of all these toys put together, so that we all will practice together. So that was a very good thing that he did, and you guys can also follow that. Next slide, sir. So I've put examples of development station. Again, these are all taken from RCPCH website, so that you will get an actual idea of what types of questions can be there. So this one of them can be a 3-year-old girl child who is Down syndrome. Please assess her speech and language development. So then you'll have to choose what all toys you want to choose, and then you'll have to assess each of these. Of course, in detail, it will come in coming sessions. But then what might be expected, RCPCH website itself has put a few clues or hints to what might be assessed. Next slide, sir. Or the next example, your command can be as vague as this, that 4-year-old child whose sibling has autism spectrum disorder. Please assess whether you think that this child also has autism spectrum. This is like very vague. No, you don't even know which milestone to check. But then you do know that autism affects their speech and language, and also the way they interact and communicate with other kids and us. So you will have to go into cognitive assessment. You'll have to assess both social, speech, and hearing in the 9 minutes that is given for developmental assessment. So these are all just examples of how difficult they can put a scenario. They could have instead of directly giving that you assess their cognition. So just that we should be ready to face anything, and that will only happen if you keep practicing. So developmental station, like I said, the first 9 minutes, you will be taking history from the role player. A role player will be sitting with you in the room. So it will be only 3 of you, the role player, the examiner, and you. You will be asking history from the role player. The examiner will only be observing you, how you're taking history, how you're interacting with them. And then once the 9 minutes is over, role player will leave the room. After that, you'll be there in the room for next 13 minutes. In that, the first 10 minutes, you'll summarize, and then you'll proceed with assessment. So in assessment, you'll only be dealing with the examiner. The examiner will act as though they are the child. You can either be that extreme, or the examiner can help you with answering questions that you're asking. For example, I'm assessing speech and language in a child. So I say, I'm taking a book and then showing it to the child. I want the child to point out to a dog here. And the examiner will say whether the child is able to point to the dog or not. So this is how the examination will go on. The assessment will go on in the exam. Or if you are like in this example, if you are asked to examine an autistic child, assess an autistic child, the examiner can actually behave like an autistic child. He may just bend down, not make eye contact with you, not interact with you. Unless you say that you're involving the mother of the child to interact with the child, he may not respond to you at all. So it can either be this extreme. And imagine if the child is an ADHD child, the examiner will keep running around, won't even sit next to you. So it can either be this extreme, or it can even be the other extreme. Either way, once we get more confident, we can definitely tackle these situations. Next slide, sir. So this is once the COVID adapter exam came, RCPCH released a video. I've attached the link. I can even share the link in the group for a development mock station where when you don't involve a patient or the child, how do you go about with the development station? This video is actually useful. You guys can see. I'll share the link in the group. Next slide, sir. So the domains that are based on which development station is assessed. Actually, development station has everything, isn't it? It has 9 minutes of history, and then it has 9 minutes of assessment, and it has 3 minutes of discussion. So it is like putting together all of the stations and then assessing it in one station. So you'll have marks for information gathering. You'll have marks for how you communicate with the child, whether you're, the role player, whether you're having good verbal and listening skills, and then both in history and communication. That's what you do. And then like in clinical station and then video station, you'll be assessed also for clinical reasoning, whether they're able to put together why the child has these issues. Like I said, it is a neurodevelopmental station. And then whether you're able to give a management planning. So development is a comprehensive station which assesses all domains that RCPCH aims to assess you based on. So maybe that's why it is very scary. But then since it is like there are schemes or formats by which you can proceed with the development station, once you come to know about it and once you can crack it, it is actually the easiest station among the 5 that you have. Next slide, sir. Yeah, so I think we have given you quite a lot of information. So if anyone has any questions, we are open for discussion. Just read through the chat boxes. One of the 4 mentors, one of us will definitely answer your questions that you've posted in the chat box. It's nice to see that a lot of discussion has happened. Yes, please.
Yeah, so it will be uploaded in the YouTube, and one in the to keep on telling the positive or negative signs which we are getting during the examination time of 6 minutes. So it will be useful if it will be convenient when we talk, so that we don't miss out at the if you have that habit, that is good. I used to do that way, but sometimes some examiners say do not talk, just examine and at that. So you have to catch the pulse of the examiner, what the examiner prefers. Remember, clinical station is one part where there is no key from RCPCH. Exactly what the examiner wants, we have to adapt.
الدرس هيبدأ فاضل ربع ساعة، تعالى عشان تخلص الهوم ورك. وريني اللي انت حليته اساسا، مش عارفه انت حليته.
Okay, then Dr. Prasanna has said verbalization during examination may or may not be done. You should practice both. So it's the same. And which books are recommended that we should cover at least once, as we discussed? Rebecca has very good scenarios, and lots of notes are also available in the WhatsApp group, so you can. Developmental station will have patients. Sorry, I think missed that part. So I think developmental station is a simulator. It doesn't have any.
Dr.
Wait a minute. I think I will mute everyone. Okay. So developmental station are not going to have patients. It's a simulation environment. Okay. How can we access to the MP4 videos on development stations in the mock exams? What is this? I couldn't understand. Harsha, can you understand this? How can we have access to MP4 videos on development stations in the mock exams?
I think he's asking about the link that I shared in the PowerPoint,
Okay.
sir.
Okay.
If that is what you're asking, I'll share the link in the group
We will
also.
share. We will share. Is there any option to see clinical cases like hands-on practice? So the only way is you being attached to a hospital, but it should be a tertiary hospital. So usually we went back to the college where we studied. So we had, so it should be a tertiary hospital where you get to see a lot of cases. Okay.
One thing I can say, sir, they can even practice with the normal children. The
Yeah.
scheme, they can even do it with their own children, or even a big dummy. So they can just practice their schema with this, and then they can, whenever they get time once in a while, they can go to the big centers and just have a day of for the clinical examination.
Yes, sir. Yes, sir. And, any other, it's open actually. So you can open your mic and discuss.
Anyone has any queries, they want to chat, or they can even ask, open their mic and ask. We can discuss.
Regarding development is one station where I think you don't have much books to practice to read. It's all about how you practice as a group and how your senior trainer helps you out. So that only is going to help you. And if you are not training, development is one place where you get more marks. 12, it's a highest mark. And if you don't perform well, we can straight away go down very badly. So development station is very important. Okay.
Yes, sir. There are no more questions, then we can wind up. We'll share this in the group, and you can see this again. Asha, you want anything to add?
No, sir, I think we've covered everything extensively.
Regarding the mock long course, we are conducting a long for 6. So those who are preparing for the exam next diet can definitely contact Dr. Harshavardhani or me in the WhatsApp group. You can message me personally. So we will put it in the group regarding the details. So we can help you out in mentoring where you are going wrong. Giving good exam scenarios is a difficult task actually. You as a group, you will be practicing, so you will be preparing all the thing, but giving a good exam scenario, that will be very difficult. So that we help you in training that aspect. So sir, you want to add about the long course?
Yeah, I think we all need one mentor. That is very, very important. So if you practice with the colleagues, then they may not tell where we are going wrong. So a mentor only can tell us where we are going wrong, and which is our stronghold. So that also a mentor can tell, and I'm sure you'll be benefited from the course.
So we are going as a system wise. So every week we will be doing one system. So we have almost 20 weeks to go about. So each week we'll be covering one system. So you can prepare accordingly. We will be, suppose you are unable to, we'll be giving the recording also to access. So it will be very useful. Harsha, you want to add anything?
Yeah, sir.
Cool.
So most of us, I think most of us would have completed a post graduation. Some of us might directly do, like for some of us, MRCPCH can even be the first step for post graduation. Either way, we all will have some clinical training. So it's not like we are starting from scratch. You just need some fine tuning, and that fine tuning, I think, can be done only by someone else. I don't think we ourselves can, fine tune ourselves. At least for that, you need other people to supervise you, to oversee what you're doing, and then give you a proper feedback. So that way, this course will be very useful. Like I said, you all will already know how to examine a cardiovascular system, how to examine a CNS system, but then how to adapt to the MRCPCH format, how do you get the scheme, how do you get the flow, so that will be very useful here.
Dr. Sabri, you want to add in?
Yes, I think the practice, having a good practice and good colleague, a short group probably it will help you in practice. And somebody senior with you who has already done the MRCPCH to tell you like where you are going wrong or where you are going right. So that way the guidance will be helped. So practice is the key here, and so that will help you in practice exams. So my good wishes to all the candidates.
If anyone wants to ask anything or discuss anything. Okay, anyways, the group is open for further discussion. If you guys have any other doubts, you can definitely post in the group. One of us will definitely reply.
Okay. Thank you all for this session. We'll wind up. Thank you.
Thank you.
Thank you everyone for joining.
Thank you.